Hi, everybody. This is Dr. Wright, and I'm here to talk to you about lipedema and lymphedema. And these, there's a lot of overlap, but they are different diseases, and most people don't understand the differences. And so I'm going to go into a deep dive into lipedema and lymphedema, and hopefully that help everybody understand the differences and similarities between them. So without much ado, here goes. So what is lipedema? Lipedema is a fat disease. It's relatively resistant to weight loss, is associated with high output lymphatic failure. So it does have some um, lymphatic impairment, but the lymph is pumping. It is characterized by so there is fibrosis in it, but it's just in the subcutaneous deeper tissue, not in the upper dermis, and it obviously is symmetrical and affects just women, and it just is mostly known for its accumulation on the limbs. Lymphedema occurs when there's a disruption of lymphatic flow because of obstruction or absence of flux of structures. It affects the whole dermis. There's fibrosis in the upper dermis, not just the subdermis. It's associated with various complications, including infection. And many people think of just lymphedema in terms of from cancer, but it's actually the most common cause of lymphedema right now is obesity, actually, and then venous problems such as blood clots and venous obstruction can also cause lymphedema. Is a very common cause of that. It's also associated with trauma, and especially like knee replacements can lead to lymphedema. So lymphedema, we'll get into more of this in just a little bit. So prevalence, lipedema is it's hard to know. It's estimated that it's occurs in about 11% of the female population. Estimates range from 5 to 20%. It's we don't have a good estimate, but that's what we have right now. Lymphedema uh, is epidemic worldwide. Over 250 million people are affected. It's about in the U.S. It's about 1 in 1,000 people have lymphedema, and it can be caused again. Um, um, One of the biggest causes right now in the U.S. is secondary to obesity. So once your BMI gets in the 40s and 50s, or that puts so much pressure on your lymphatics that it can cause a secondary lymphedema. So this is a diagram of how the lymphatic system works, and it's important to understand. So most people understand the arterial venous circulation. That's a closed system, and as you can see here, it starts the heart, pumps through the arteries to the veins, and then returns back to the heart. But uh, lymph is an open system, so it starts in the tissues. It's generated from the fluid that leaks out of the capillaries, and then it's open into the tissues, and then it then is collected up into lymphatic collectors, and then they take it to the lymph nodes and then filter it, and then some of the fluid is returned into circulation. So this is sort of a schematic of these lymphatic capillaries, and then they go to the bigger collectors, and that helps us appreciate lymphatic circulation. So lipedema affects mobility, can cause disability because of inability to do activities, climbing stairs, getting in and out of tubs, etc., getting out of chairs. It can cause a secondary lymphedema. It can cause it can lead to orthopedic changes, including arthritis in the knee, hip, and ankles. So it can impair and the everybody's quality of life, and even lead to disability, and increase the risk of even mortality, which I'm just in another paper I'm just publishing now. I'm able to show links at how it can indirectly correlate with overall mortality. So lymphedema also causes immobility, and is a leading cause of disability. It also, because the lymphatics are impaired, it increases the risk of infection and even cancer in the areas where the lymphedema occurs. So in a leg with lymphedema has an increased risk of developing cancer, and part of that's because the immune compromise in the area of where the lymphedema is going on. So that lymphatic circulation is not just moving fluid. It's actually part of our immune system, and it is how we fight infections and heal. And so impairment of lymphatics is serious. This is a picture of lipedema. So there's a classic lady who has what we call type 3 lipedema. You can see here that there's columning over the legs. That means there's like a column of tissue over the legs, actually hanging. Even the thigh tissue actually hangs over the knees, and see kind of a lobule at the knee, and then cuffs down at the ankle. And so this is a classic lady with lipedema and the changes. Now you can see here her foot, she has the cuffs, and she has her feet are spared, and that's kind of classic for the diagnosis lipedema. So if you the swelling and stuff is limited to the ankles and above. And this is another lady. This is a stage up called stage 3, and you can see here that she's developed lobules. So these are just like excrusions of fat, and on her lateral thighs, and kind of even kind of a lobule on her calf, and then she's got lobules on her arms, and they can be quite quite bothersome, and interfere with activities, and they're heavy. This is lymphedema. So this is a lady with this is advanced bilateral lymphedema, and she has she has cuffs and lobules, but you can see here the swelling extends into the feet, and then you can see their skin changes. So she has so you can see the rippling on there. That's fibrosis of the skin, and leading to these ridges, and so it's all the way through into the dermis. And now she has these large lobules of swollen tissue, and that is in the thighs as well. This is a more classic sign of lymphedema. This is just involving one foot, and the other foot is uninvolved. And so if you pinch the top of that, the skin won't pinch, and that's what we call a positive stemmer sign, and that's classic for lymphedema. So physical signs, I kind of went over the cuffs. While they cover both, they're more known for in lipedema, lobules, negative stemmer sign, progressive. The stemmer sign is negative, and the progressive mobility issues, and then the lymphedema, the stemmer sign is almost always positive. The skin changes through, including the fibrosis and the progressive enlargement. Usually lymphedema is often in one limb, and is generally asymmetric. So even if it does affect both limbs, one limb is usually affected more. Treatment: both lymphedema are treated with compression, a low carb diet, which and lymphedema therapy, complete decongestive, and then intermittent compression pumps, and So those are the mainstays of treatment. So there there is a lot of overlap or similarities between the two treatments. Lipedema, lipedema is very responsive to lipedema reduction surgery. It's one of the most successful successful treatments, or most can give some of the biggest benefits. It should be done for people who have done conservative therapy and still need relief. So studies have shown that the lipedema reduction surgery can improve pain, swelling, decrease the need for compression. We also can do a reduction surgery in lymphedema, but that's not as often done, and most of the time lymphedema is just managed with non-surgically with compression. This is a before and after. On the left is before lipedema reduction surgery, and you can see here there's quite a bit of tissue is removed, and this improved her mobility, quality of life, with lipedema. She had type 3, stage 3 lipedema with the lobules and it was impairing her mobility. Mobility improved significantly after the surgery, and her overall quality of life improved. This is just before and after, showing like one of these lobules on the inner knee before and after surgery, and even that can, just even removing that lobule can improve the knee flexion and range of motion and mobility. So, and as well as they can be very heavy and tender, and that reducing that lobule gave her great relief. This is a side view before and after, and you can see there's this columning of lipedema tissue over the knee, and then after the surgery that's reduced, and that can help the mobility and pain and symptoms of lipedema. And here's an arm with affected by lipedema before and after lipedema reduction surgery. So I spoke about how it can improve knee range of motion, valgus, and I'm just getting ready to publish some data on that, and how it can improve the knee flexion, gait, and alignment of the knee. So following lipedema reduction surgery, we saw an improvement in knee flexion by 8 to 9 degrees, and a significant improvement in the gait. These improvements in knee flexion and gait are quite striking, and are similar compared to what we see in knee surgery. I'll get into that a little more. This is how we measure knee flexion. This is called a goniometer, and we line it up with the femur and the fibula, and this is a lipedema lady who you can see there's a lot of tissue in the thigh and calf that are preventing the full flexion. So she's at around a little under 90 degrees of flexion, and that's way below normal. And as I showed you earlier, that affects things that, so at this kind of flexion, it's difficult to go up and down stairs, and difficult to get in and out of cars, etc. And then this is the green area here is where it should be, and that would be, more. That would be like 140 degrees, which would be a normal knee flexion, and that would be that's kind of our goal for our lipedema ladies, is to get them as close to normal as possible in their flexion and mobility. So we studied this, and we looked at these patient reported medical outcomes, and that's the PROMISE and RAND, and they were developed by the NIH and the RAND Corporation, and they're used widely. They're 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 normalized to the U.S. population, and they also are used in many other diseases. So we can compare the improvements we see from lipedema reduction surgery with with improvements seen with other surgeries for other diseases. So Rand, so this is the SF-36. So um, medical outcomes, and we can see on all sorts of components of overall health, such as physical functioning, role functioning, energy, fatigue, emotional well-being, social functioning, pain, and general health. They all started well below mean, and some improved to above the mean, or just below it. And that's those are all statistically significant. This is that same data, just showing there's just graphed, uh, and then we can see here, over each of these domains of health, that there's improvements after the surgery. Here is some of the PROMIS data, and we see here that that there's a 15% increase in the ability to walk at a normal speed, and that is significant. That's statistically significant, but it also is significant in terms of this, like normal gait speed is associated with a lot of measures of health, and declining gait speed is associated with disability and even future mortality. Similarly, we saw an 18% improvement in the ability to go up and down stairs, and that stair ascent and descent is another key indicator for overall health, mobility, and predictor of future disability and even mortality. And then we also showed significant improvement in ability to get up from a chair, and all these things are very show very significant improvements in important measures of overall health. So when we compare lipedema reduction surgery to a total knee arthroplasty or knee replacement, these are our data are from the lipedema reduction surgery are every bit as good. We are showing similar improvements in overall mobility, overall quality of life, and activities of daily living, using the exact same validated measured tools, have comparable mechanical improvements in knee flexion, comparable improvements in quality of life, and these are quite striking, and really are able to show that this surgery can have the same kind of impact in someone's health as a knee replacement. Well, that is all my time, and I really appreciate your interest. And if you have any questions about this or anything, please put them in the comments. I really, I'll take some time to answer them, and I hope this is helpful to the people. And again, thank you again for listening, and wishing you all the best of health. So goodbye.